Hi, I'm Bill Prentice. I'm the CEO of the Ambulatory Surgery Center Association. We're obviously the national trade association for ambulatory surgery centers. I appreciate that my friends from Garfunkel Wild have given me a few minutes to talk with you about ASC issues at the federal level. I know I'm joined in this panel with some representatives from the tri-state area. We'll talk about ASC issues at the local level. And hopefully between those two perspectives, you'll get a good understanding of what's happening in the ASC marketplace, both nationally, and in the local tri-state area. From my perspective, I think I'll talk for a few minutes about three primary areas. I'll talk about, Medicare policy, particularly on the payment and procedure side. I'll talk a little bit about our some changes that are potentially upcoming with regard to quality reporting. And then I'll also spend a minute or two and talk about our ASC legislation. First and foremost, though, I think I'll give you a quick overview of kind of where things stand in Washington, D.C. As you're sure well aware, we have a Democratic administration with the Biden administration. We have a narrow majority in the House of Representatives for the Democrats, and a very, very narrow majority for the Democrats in the Senate, with the requirement is actually 50-50 with Vice President Kamala Harris providing the tie-breaking vote to give the Democrats a very, very slight narrow majority in the Senate. And what that's resulted in, as you can imagine, those narrow majorities, is that it's very hard to get legislation passed into law. We're seeing that right now with some of the major objectives of the Biden administration in terms of their Build Back Better infrastructure plan and their hopes to create this anywhere from $1.5 trillion to $3.5 trillion economic plan. Those figures are for covering a 10-year period, so that's not trillions of dollars in one fell swoop. But again, that's really kind of the major priorities for the administration right now, is to try and get those two massive pieces of legislation enacted. The latter, the economic plan, which does have some healthcare spending and healthcare programmatic changes involved in it, but at this point, nothing that I think is going to directly impact ASCs, right now. But to go back to things that are really right in front of us and will impact ASCs, I think we have to start with our Medicare payment rule. As you may know, the proposed rule came out this summer. There was a comment period that was open from the middle of July through the middle of September. We obviously submitted a number of comments on that proposed rule on a number of different provisions, and I'll talk a little bit about that in a few minutes. That comment period closed, and we're expecting the final rule to be brought out sometime on or about the 1st of November. And so we'll have 2 months, the months of November and December, to help educate you all about what is in that rule and how it impacts you and how it may change or impact the way you operate your ASCs. Let's start with payment policy. One of the things that we were very successful in getting convincing CMS to do a few years ago was for at least a 5-year trial period to update ASCs for inflation, so the payments you'll receive from Medicare in 2022, using the same inflationary mechanism that is used for the hospital outpatient departments and inpatient hospitals. That inflation factor is known as the hospital market basket. And why that matters is that hospital market basket looks at the increase in prices of goods and services and salaries in the hospital sector, in the healthcare sector, which I think is a pretty accurate way of trying to judge the inflationary impact that's happening for ASCs as well. So we were very successful in convincing the prior administration, the Trump administration, to update us using that same inflation factor. And we're very pleased to see that the Biden administration in the proposed rule said that they would do the same thing this year. Now, again, everything that I'm talking about in terms of this proposed rule is subject to change, because until that final rule comes out November 1, we won't know exactly what policies are being, put into effect. However, I think, so everything I'm saying is perspective, but I think we have a fairly good sense that they're going to continue to update us using the hospital market basket for at least this 2022 year. So that update factor for this year is 2.3%. Again, the same inflation amount for HOPDs. I think one could argue that because of what we're seeing in inflation right now in the overall economy, that may actually be smaller this year than if we had used the CPIU. But I think if you look over a longer span of time, that hospital market basket is the more accurate way to update ASCs for inflation. One of the things that continues to trouble us when it comes to ASC reimbursements is the fact that CMS uses a budget mechanism that is known as the weight rescaler that actually artificially depresses ASC reimbursements because of the way that CMS budgets for healthcare spending. And essentially what happens is that CMS is required to produce a budget neutral payment system, meaning that other than the increase in volume that would pop up, they're supposed to try and keep Medicare payments budget neutral except for that inflationary increase. And one of the complicating things is that CMS makes that budget neutrality decision in silos, meaning that they make a budget neutral decision for ASC reimbursements, for HOPD reimbursements, for inpatient reimbursements, for physician reimbursements, and doesn't look at the overall impacts of where migration is occurring, where payment procedures are moving from one setting to another. And adjusting for that and paying reasonably based upon that, looking at where payments are being made in each silo. It's a long way of me saying that because we are, if this budget neutrality decision is made in an ASC silo, the more procedures that migrate from the HOPDs to the ASCs actually has a negative impact on overall ASC reimbursements. And so what we've seen in the past is that we are getting reimbursed less for some of our most common procedures, even with getting an inflationary increase. We don't think that makes sense. We think that ASCs should not be penalized if Medicare beneficiaries choose to go to an ASC rather than HOPD, and as a result, we have increased volume in that that budget silo, which ends up resulting in, again, lower reimbursement for some of the more common things we do. Something we think CMS has the power to change. It's something that we're actually going to try and ask Congress for some help on, and I'll talk about that in a few minutes when I get to our legislative agenda. But it's something that really is perverse, that ASCs actually get penalized the more Medicare volume we bring into our setting. So second area of focus for us is obviously procedures. Again, this is a really odd year. Some of you may recall that in last year's final rule, CMS made the decision, and the Medicare program made the decision to actually do away with the inpatient only list, which were the procedures that, surgical procedures that could only be performed inpatient, and actually take 1/3 of those, generally the orthopedic and musculoskeletal procedures, and allow them to be performed outpatient only in the HOPD setting. This was a bit of a surprise to us. We hadn't asked for that. The hospitals hadn't asked for that. But last year, the Trump administration decided to make this really profound change and allow these procedures to be performed based upon the clinical judgment of the physician, either inpatient or outpatient. Again, not in the ASC setting. Indeed, the biggest concern we have with the way that that change was made last year is actually there was a kind of a poison pill sentence in that proposal that we think was unintentional, but actually would have forever prevented any of those procedures that were now going to be able to be performed in the hospital outpatient department to ever be performed in the ASC setting. And that was something that we were looking to change this year had they continued with that policy of doing away with the inpatient only list. Really surprisingly though, instead what CMS decided to do this year, in the first year of the Biden administration, was actually to reverse course completely in terms of doing away with the inpatient only list, and to actually take those procedures that had been permitted to be performed in the HOPD in 2021 and pull them back into inpatient only procedures. We thought that was jarring and wrong, and I think was really showed, I think, a disregard for what I thought was a really good, understanding in last year's rule, that the clinical judgment of physicians was really the most important determination about where procedures should be performed. And something that we thought was a good sign that the medical directors at CMS were realizing that rather than them arbitrarily through their rulemaking determine where procedures could be safely performed, to actually allow the clinical judgment of the physicians and surgeons to determine where was the most appropriate site of service for a given beneficiary to receive their care. Similarly, in last year's rule, they actually added more than 200 procedures from the HOPD list to our payable list, meaning procedures that we could perform on Medicare beneficiaries and being reimbursed by Medicare. Again this year, in a similar jarring way, CMS pulled all that back as well and put all those procedures back on the HOPD list. We think that there was a significant number of those procedures that were added last year that ASCs can safely perform, have safely been performing on commercial patients, and that we should be allowed to continue to be reimbursed for under the Medicare program. We very strongly in our comment letter pointed out the inconsistency of what CMS did last year in terms of adding all these procedures, either available to HOPDs or to ASCs. So basically moving a big bolus of procedures to be performed on the outpatient basis and pulling those all back arbitrarily. One of the things that, we find most concerning about that was the fact that, they seem to have the same medical directors that thought it was safe to move those procedures last year have suddenly reversed course this year. And so we really called attention to that. We think that was a mistake and something that we hope that they will address in the final rule when it comes out on November 1. One of the things that, people fail to understand is that just because a procedure is, put onto the HOPD list or the ASC list, it doesn't mean that all those procedures are actually going to move to that setting. So even the procedures that are on our ASC reimbursable list, a physician can make the determination that she believes that patient's better seen in the hospital, outpatient department, or even inpatient to have that procedure performed. So the fact that we are allowed to do a procedure does not mean that all those procedures will move. It just means that the clinical judgment of the physician is going to be the best determinant of where that patient receives care. And I think if we can convince CMS and the medical directors of that, and the fact that it's the clinical judgment that should be the true determinant of where procedures are performed, hopefully they will see the light of day and allow many more procedures to be allowed to be performed in our setting. And that's something that we're going to be working really hard on going forward. Another element of this proposed rule that we were really excited to see is they made a change to the device intensive policy that they have used to determine when Medicare will pay separately for a medical device in a procedure being performed in an ASC setting. You may recall that we have been successful in years prior in terms of lowering the threshold of the types of procedures that can be reimbursed separately in the ASC setting. It used to be that the procedure had to cost more than 50% of the overall cost of the procedure performed in the HOPD in order to be reimbursed in our setting. We were able to lower that to 40% a few years ago, got it down to 30%. This year, they've actually made a significant change in terms of that 30% determination is going to be based off of the cost of the device based upon the procedure cost in the ASC setting, not the HOPD. And that's going to allow a large number of formerly non-payable device procedures to now be allowed, where the ASC will be now allowed to recover the cost of the device. That's, I think, going to allow more device-intensive procedures to be performed in the ASC setting on Medicare beneficiaries. Last area of Medicare policy that's in this rule is some significant changes on our quality reporting program. You may have noticed over the past few years that there was really not much interest on the Medicare programs in the Medicare program in terms of adding additional quality measures to our program. Indeed, a couple of years ago, they actually reduced the number of measures in our program. They actually eliminated ASC 1, 2, 3, and 4, which were the first 4 measures that we had in our program. You may recall them. They were the wrong site procedure, wrong site, hospital transfer, patient burn, and patient fall measures. This rule proposes to bring those measures back. It's something that we're actually supportive of, even though we did really, really well in those measures, and that was one of the reasons why CMS decided to mothball them, because we were essentially performing so well on them that the Medicare program didn't see much value in us continuing to have to report on those great successes in those measures. They've decided to bring those back. What we've actually asked for is that to not only have us continue to report on those 4 measures. Historically, we've only had to report on them for Medicare procedures, Medicare patients. We'd like to actually report on those 4 measures for all patients. First of all, we think that's actually, from an administrative standpoint, easier for ASCs to do rather than have to try and pull out only the Medicare patients and their on those 4 measures and actually report on all of them. We'd also like to see that those same 4 measures be applied to the HOPDs so that we can actually see a true comparison on how ASCs and HOPDs perform on those 4 very simple elemental measures of safety. So we'll be interested to see what CMS decides to do at the end of the day with those 4 measures. 2 other big quality measure initiatives that we have some concerns about. One of which is they have decided, you may recall a few years ago, they had proposed to do a visual function measure for cataract procedures, where they wanted to have a pre-surgery and post-surgery reporting of visual function and have ASCs and HOPDs report on that. Both we and the hospitals fought back on that measure a few years ago by noting that it's not a measure of the quality of care being provided in the ASC or the HOPD, and that the data that they're requesting, the ASC doesn't possess. It would be the visual function before surgery is something that would be housed in the ophthalmologist's office, as would be the 90-day visual function, after surgery data. Neither of those data points are in possession of the ASC. It would be a huge administrative burden for us to figure out how to collect that data. Hospitals have been making that same argument. It's obviously a physician measure, not a ASC or HOPD facility measure. So we're really hoping that the CMS will see the error of its ways and pull back that quality measure because it just doesn't belong in our setting. The last area of focus in terms of quality reporting is they have once again proposed to require an OAS CAPS measure, a patient quality measure that we had embraced actually years ago, but had real concerns about the implementation and the way we would collect that CAPS data. As you may recall, when that measure was first offered up a few years ago, our concern was that it had to be that patient satisfaction data had to be collected by either phone or by mail. That there was no electronic option to be able to collect that data from the patients. This go around, there is an electronic option, but you still are also required to have either phone or mail as another option for collecting the data. We think an electronic only option really makes sense. We think that the CMS is way off base in thinking that Medicare beneficiaries don't have access to computers and to email. We think that would be obviously the most cost efficient way of collecting that data. We're hoping that they will create an electronic only option. That's what we've asked for. And we'll have to see what ends up happening when the rule is finalized in November. Turning quickly to our ASC legislation, we always recognize that there's some things that we can ask of the administration to take care of by rule, like through this Medicare payment rule. But there are other things that we want to see addressed in terms of the way ASCs are treated at the federal level that require an act of Congress, that we require the House and Senate to pass legislation, the President to sign it, and in order to make some changes that we think are long overdue to try and help ASCs in the ways that they work with the Medicare program primarily. So we're introducing our ASC legislation. I'm recording this in the middle of October, and I think that our ASC bill will be introduced in a couple of days on a Friday. We have great sponsorship in both the House and Senate for this legislation, and we're going to be asking all of you to help us to get your members of Congress to sign on and become co-sponsors of this legislation in both the House and Senate, so that we can build momentum for these provisions, and whether we get the entire legislation signed into law or just different provisions of it added to another piece of healthcare legislation and signed into law, that we can get some of these things turned into statutes to try and help ASCs. Our sponsorship in the House is led by actually a member from Connecticut, Congressman John Larson, a senior member of the House Ways and Means Committee. His Republican co-sponsor is Congressman Devin Nunes from California, also a senior member of the House Ways and Means Committee. It's really helpful when you're trying to pass legislation to have the lead sponsors be members of the committee who have to vote on the legislation first, and that's what we really tried to do with this legislation. On the Senate side, again, we have a representative from Connecticut, a senator from Connecticut as one of our lead sponsors, Senator Richard Blumenthal from Connecticut, and he is joined on the Republican side by Senator Bill Cassidy from Louisiana, who is himself a physician and has a great expertise on healthcare issues. So if you look at our House and Senate co-sponsors, we really have great leadership, great sponsors, but we obviously need more help in terms of getting other members of Congress to sign into that bill. And I hope that once the bill is introduced and we send out our email asking for you all to help us reach out to your members of Congress, that you'll do so that we can get a large number of co-sponsors, both Republican and Democrat, House and Senate, so that we can create pressure on the committees and on leadership to get these provisions signed into law. As you probably know from prior Congresses and prior introductions of this legislation, one of the things that we have in this is a requirement to make that hospital market basket inflation factor the mandatory way to update ASCs for inflation. As Ed mentioned earlier, we've been very fortunate for the last few years that CMS has been applying the hospital market basket to ASCs, but they're not required to do so. So if we can get this requirement put into statute, it's going to ensure going forward that we will continue to be updated using the same inflation factor as the hospitals, which is, I think, of great importance. Another provision that we have is to require an ASC representative to be on a panel that advises CMS on Medicare payments and Medicare procedures. We currently have a representative who has experience in ASCs on that panel, but that's really because he works for a large hospital company, and it's only that he has prior great experience in the ASC community that we have someone there who's speaking up on our issues. We really deserve to have someone from the ASC community as a permanent seat on that panel to make sure that our perspective is taken into consideration as CMS is being advised on payment and procedure policy. A couple of new provisions that are in this legislation. I mentioned the weight scaler, and that's something that we really want to get addressed. Is to have Medicare not use the weight scaler as a means of depressing ASC reimbursements artificially, because it just isn't right, and it's actually works against the Medicare program in terms of trying to incentivize ASCs to do more procedures and to bring more volume, more Medicare volume into your office, because as you do that, unfortunately, over time, it results in actually lower reimbursements. And then finally, there's a really perverse disincentive for ASCs baked into Medicare policy, which is that over a decade ago, hospitals got a copay cap applied to Medicare procedures that basically limits the amount that a Medicare beneficiary has to pay in terms of a copay for a Medicare procedure if it is performed in the hospital setting, and it's roughly $1,400. And so no matter the cost of the procedure that the beneficiary is receiving in the hospital, the beneficiary knows that he or she is not going to pay more than that $1,400 copay because of this cap. Unfortunately, that copay cap only applies in the hospital setting and does not apply to ASCs. Now, there's a historical reason why that probably happened. This predates me being at ASCA. But I think that, back when this copay cap was enacted, ASCs really weren't performing expensive Medicare procedures. We weren't doing total knees or total hips, procedures that likely would have resulted in a Medicare copay for the beneficiary that would have exceeded that cap when it was applied. Obviously, we now are performing a number of procedures where that copay cap creates a perverse disincentive for the beneficiary to want to get care in the ASC. Because even though the cost of a procedure may be significantly less for the Medicare program and we as taxpayers, if it's performed in the ASC versus the HOPD, this copay cap actually makes it less expensive for the beneficiary to choose the more expensive setting, the hospital, rather than going to get the ASC. So we really need a copay cap for ASC payments to basically do away with that perverse barrier that makes it more expensive for a beneficiary to get care in the ASC than the hospital. Well, I think I've exhausted my time here, but I want to again thank my friends from Garfunkel Wild for giving me a little time to talk to you about some of the things that we're working on. I want to really hope that everyone who's listening to this is an ASCA member and a member of your state ASC association. We work hard every day to try and protect the ASC model, to try and pass legislation and regulations that allow you to do your jobs better, to provide great care to patients that in the most efficient way possible. So I hope you'll join ASCA. I hope you'll join your state association. I also hope, regardless of that you will pay attention to our advocacy messages and be an advocate for the ASC model. Meet with your lawmakers, both at the federal and state level. Explain to them what you do and why what you do is so important to our healthcare system, and that how you are trying to bring, efficiency and rationality to healthcare, providing great care to patients at a more efficient price. So with that, again, I thank you, and I hope you enjoy the rest of this conference.